top of the hour, so we'll go ahead and get started. Hello again, everyone, and welcome to our first live session of the second annual People of Color Living with Diabetes Summit. My name is Quisha Umemba, co-founder and president of Diversity in Diabetes, and I am honored to introduce our speaker for the hour. The COVID-19 pandemic has revealed disproportionate impact on Blacks, Indigenous, and people of color. Health technology, which was meant to alleviate racial inequities in treatment and resource access, continues to reveal a lingering gap. People of color living with chronic conditions, including diabetes, are significantly impacted by inequitable health technology use. In order to combat these health inequities, TechQuity, the strategic development and deployment of technology to advance health equity, is a must. I love that. In this talk, the following will be discussed. What is systemic medical bias? How does it specifically impact people of color living with diabetes? Your presenter is Dr. Harpreet. She is a behavioral scientist, psychologist, and writer. She is a PhD in psychology and is the VP of Behavior Science at OneDrop, a digital health company that leads the way in integrating behavioral data science to support persons living with chronic conditions. Dr. Nagra has 15 years of intervention experience in individual, group, and digital health design. She has served as an instructor, lecturer, and adjunct professor at such institutions as Oregon Health and Science University and Purdue. She brings a powerful combination of clinical and behavioral science to serve product design in digital health, and we are so glad to have her with us today. Without further ado, the floor is all yours.
Thank you so much. I'm going to actually, we all know the title of the talk today, so I'm going to start off by introducing a previous patient, a client of mine, as well as somebody who is directly impacted by some of the biases and concerns that we're talking about today. So we're going to meet Marcel. Marcel, obviously that's not her real name. She is a 37-year-old Black American female. She was originally diagnosed with type 2 diabetes, but recently correctly diagnosed with type 1. She lost her job during the pandemic, and she's a single mom. And at this time, she's navigating the healthcare system with type 1 diabetes whilst managing her home life as well as her financial challenges. And now, switching from type 2 diabetes to type 1 diabetes, figuring out what the healthcare system differences look like there. So we're going to keep talking about Marcel and how some of these challenges that we're going to label today have impacted her directly. So as Keisha mentioned, my name is Dr. Harpreet Nagra. I am a licensed psychologist and VP of Behavior Science. So my job in a nutshell is to combine the insights that we get from psychology as well as the insights from behavior science, which is a science focused on how we make decisions, why we end up doing the things that we do, how our environments shape our choices, lifestyle decisions, etc. I combine all of that to help design more effective interventions for digital solutions. So I don't think it'll be surprising for any of the folks here that diabetes is a prevalent condition amongst the US community across the globe. But at this point, approximately 1.5 million individuals are diagnosed with diabetes annually. And of those 1.5 million, communities of color make the biggest, comprise of the biggest segment of those of that data. So 14.7% identify as American Indians or Alaskan Natives, 11.7% as non-Hispanic Blacks, 12.5% as Hispanic, 9.2% as Asian American, and 7.5% as non-Hispanic whites. So as you can see, despite people of color representing higher percentages, the types of interventions and technology, diabetes-related technology that's available to them and that's regularly adopted amongst communities of color is fairly low. So what is diabetes technology? I know there's a lot of people living with diabetes on our seminar today, so this won't be a surprise to you, but if there are healthcare professionals or others who are new to this language, When we talk about diabetes technology, we're talking about hardware, devices, software that people living with diabetes use to help manage their blood glucose levels. What we want to do is stave off any sort of diabetes complications from the long term. We want to reduce the burden of living with diabetes and improve quality of life. Historically, when we talked about diabetes technology, it was only related to how insulin was administered, whether it was by syringe, pen, or pump, or blood glucose monitoring, or obviously the continuous glucose monitor. But more recently, more hybrid devices that include both monitoring of glucose and delivering insulin, sometimes automatically, have been introduced, as well as software that serves as a medical device providing ongoing diabetes self-management support. And one of the things I'll talk about later on today is how the pandemic has influenced and basically propelled digital health technology to create more digital solutions for ongoing chronic illness management. So what is the impact amongst communities of color in regards to diabetes technology use? So there were a few more recent studies completed by the T1D exchange that looked at how folks of color were utilizing diabetes technology. So non-Hispanic Blacks were reporting higher rates of diabetic ketoacidosis, such as DKA, and severe hypoglycemia. However, they had the lowest rates of both insulin pump use and continuous glucose monitor use compared to their non-Hispanic white counterparts. Similarly, amongst Hispanic communities, a significantly lower insulin pump and CGM use was reported compared to, again, non-Hispanic white counterparts. Another obviously sort of major impact that we've seen is with COVID-19, many folks have low-income Americans living with diabetes have lost some or all of their income during the pandemic. So this has highlighted many of the health disparities and inequities that Americans from underserved communities are experiencing. So let's talk about what is the current state of systemic bias. How is it being addressed when it comes to diabetes technology use? We see that communities of color with diagnosis of diabetes are at higher risk of more complications, more severe challenges, more hospitalizations that include going in for DKA, but adoption rates of that technology is lower. So what has been done about it thus far? The American Diabetes Association CEO, Tracy Brown, she has, this is a direct quote from her, she mentioned, quality, affordable healthcare should not be a privilege, but a right for all Americans. It's time to tear down the systemic barriers that separate us based on zip code, income level, education, color, and gender. And it's time that we demand health equity now. So the ADA has created their own version of what are called Health Equity Bill of Rights. So it consists of 10 different Bill of Rights that they're wanting to further to make sure that we are encouraging health equity efforts. I'm going to show you a very quick video that came directly from the American Diabetes Association that captures this idea.
Inequity isn't invisible. To see it, all you have to do is be willing to look. Education, housing, income, and access to healthcare are underfunded and undermined for people of color and others who are underserved. The result? Systemic health inequity. In fact, a cynic might note that wealth equals health. Look no further than diabetes. It increases the risk for other serious illnesses, including dying from COVID-19. Diabetes is the bellwether not just for the health of our communities, but also for the health of our healthcare system and the health of our society. The inequity causing diabetes isn't invisible. The burden isn't shared. From those who are most likely to live with diabetes to those most likely to suffer complications, and the Americans most likely to die from it. Confronting the reality of diabetes is confronting the reality of health inequity in America. Inaction is no longer an option. Health equity is a right, not a privilege. No matter your race, income, zip code, age, or gender, it's time to demand health equity now.
So this was part of American Diabetes Association's effort to make sure that we're showing up at the table, we're having these conversations. It's part of our regular discussions when we're designing interventions, when we're thinking about what's going to improve both treatment and intervention over time for communities of color. So the Health Equity Bill of Rights, I'd encourage you all to review it at a later time, but it includes 10 basic rights. And I included the general categories here, but basically it says that all folks should have access to affordable insulin and other medications. We've seen the price of insulin significantly increase over the course of basically from the time that it was created. We've seen exponential increases. At one point, it was around 75 cents per milliliter, but now we know that one vial can go for up to $350 to $400. And it's a life-saving drug, but you all know the impact of insulin in day-to-day life. Other aspects of this basic right Bill of Rights include access to healthy food. So not making sure that there aren't food deserts all over America, and improving access to healthier food and encouraging folks to both access it as well as integrate it into their day-to-day lifestyle. Making sure that folks have their appropriate insurance to cover their diabetes management, sharing and notifying all communities of color about the latest medical advances when it comes to diabetes management, the right to stop prediabetes from becoming diabetes for those who might be on the road to type 2 diabetes, and then the right to avoid discrimination. So these are some elements that are now being further discussed and highlighted in the research studies that that the American Diabetes Association is putting forth. So what is getting in the way? We have this sort of national organization around diabetes reinforcing this Bill of Rights. We've had all this information from being sort of surfaced during the COVID-19 pandemic, yet we're not seeing changes as quickly as we would want to in terms of improving technology use, access to technology, discussion of technology, et cetera, when it comes to managing diabetes. So I'm going to share with you some of the common cognitive biases that are present within the medical system. The healthcare system consists of doctors, endocrinologists, other specialists, but obviously they're all human. And these are cognitive biases that are present for all of us. So because doctors are human, they're also going to be susceptible to these cognitive biases when they're making their reports, their diagnoses, and talking through different treatment options for folks. Before I do, let me do a quick overview of why this is important and how our brain is impacted by the different biases that we have. So usually when we are making any type of decision, we have two separate pathways, or this is how it's being defined thus far in the behavior science world. We have two systems that through which our information is filtered. System one is more of our intuitive, instinctive system. This is our main way of surviving day to day, making all the decisions that we need to make. It's sort of our unconscious, fast, associative, almost autopilot side of our brain. And we're more likely to utilize this because essentially that's what our society is valuing and reinforcing over time. The quicker we are at decision making, the more decisions we can make, the more productive we can seem, the more effective we can seem at our jobs, in our home life, etc. So there's a big social component around this that says make as many decisions as you possibly can, as quickly as you possibly can. So that's system one. System two is our more rational thinking system. So this system takes a little bit more effort. It's slow. It requires us to engage in deep analytical thought, logical thought. However, it can socially be considered to be our lazy brain, or the slower part of our brain, because you are taking your time to deliberately think through what is the right option, how do I apply all these sources of information to my to the problem at hand, right? So we are not reinforced socially as often to utilize our system 2 because of the fact that it takes longer, it takes more information, it requires us to be more deliberate over time. So we just tend to use it about 5% of the time. So how does this impact our relationship to the healthcare system? Like I said, doctors are also human beings and therefore also susceptible to the system 1 and system 2 way of thinking, right? And if we consider the other aspects of what a doctor has to do on a day-to-day basis, we know that they're seeing multiple patients, they're working in a hospital setting potentially, or a clinic where there are they also have additional pressures like quotas that they have to meet, financial costs, et cetera. So they have to basically see as many patients, support them as quickly as they possibly can. So here's an environment where system 1 is highly valued, and system 2, despite it having its benefits, is not as often reinforced along the way. I'm going to share with you 4 different types of biases that are probably the most common and potentially the most dangerous when it comes to how communities of color interact with the healthcare system. And these 4 include an anchoring bias, a confirmation bias, affect bias, and availability bias. I'm going to walk through each of these. The reason why these cognitive biases are worrisome, just to sort of set the context, is that it impacts a doctor's ability to gather all the sort of evidence that they might need to make an informed decision. It impacts their ability to interpret the evidence. So if they have to make a decision quick, they might need to potentially leave out certain sources of information. It's also worrisome because it impacts how they take action. So they might be more inclined to take action more quickly if they have to decide quickly, and maybe the options that are available to them will become more limited, and that might include skipping over what might be more challenging conversations when they're meeting with a patient directly. Also, it might limit how they are evaluating the decisions that they are making on an ongoing basis. So let's say a misdiagnosis was made. However, because that was originally decided by that person, that doctor might then kind of hunker down and say, I absolutely back up this decision. I'm not going to look at other resources of information, et cetera. And they may not be as inclined to change the diagnosis as quickly as might be necessary to support a person living with diabetes. So these are just some of the reasons why it's worrisome that these cognitive biases exist in how folks are diagnosed, what kind of interventions they receive, and what kind of treatment they receive in the healthcare system. So let me go through each of these and describe them in a little bit more detail. Anchoring bias refers to how we prioritize data or information that supports our initial impression, even when that impression is incorrect. So sometimes this comes at the cost of ruling out other potential causes. So a good example of this is when you enter the grocery store, the items that you see upon entry, they set an anchor for what the pricing in the rest of the store will look like. So if you see only the items that are on sale up front as soon as you enter the store, that creates a bias for all of us that the rest of the items in the store might be cheaper because we were initially anchored to this idea, introduced to this idea early on as soon as we walked in, that the store has cheap food or cheap resources available, right? A different version of this you'll often see this on websites where they'll have an original price listed, but then it'll be striked out. There'll be a line through it. That number says, look, this particular person is now this particular price is no longer a part of the sale. So why don't you buy more now that it's cheaper and easier to access this product. So it's, again, anchoring you to what the price used to be, which was a higher price, and telling you now it's cheaper, so buy more of it, right? A job example of this is when you're negotiating your salary with whoever the recruiter might be for your new job. They're going to typically give you a low figure first. So it's important that you continue to negotiate as a way to help you get to the type of salary that you want. But the idea is we're going to pay you, most employers want to pay you whatever is most doable for them, right? So it might be a low figure, but that figure may not line up with what you want for yourself. Another example of this is when you're buying cars, salesmen will start at a higher price up front, and then they'll show you cars that are lower priced later on as a way to get you to buy that car using this particular anchoring bias. Same thing with houses. Real estate agents would show you a really bad house first to help you, to basically make you increase your budget, and then they'll show you a very much a nicer house to get you to increase your budget and buy a house directly from them. Okay, so how does this go back to Marcel, our example from earlier? So let's say Marcel is showing up for her appointment. She shows up with her young child who's cranky from a missed nap and who's crying throughout the entire medical appointment. The doctor may have a perception that Marcel is an overwhelmed mother. She has limited resources, that she may not want to try out novel technology at this time in her life because she's already got so many other things going on. And there might be a perception that she may not be able to afford the technology. So all of these ideas and biases, these assumptions about Marcel are going through the doctor's brain prior to even having the conversation with Marcel about what she might want to do in regards to her diabetes treatment, right? So that is anchoring bias. And again, it's dangerous for all the reasons that we talked about. And Marcel is already experiencing a misdiagnosis. So she was diagnosed with type 2. And now she's currently being treated for type 1. So she's already been victim to this particular bias thus far. Another common bias is confirmation bias. So you might have heard about this one in pop psychology. So this is when we selectively gather and interpret evidence to confirm our own existing beliefs. So this comes at the cost of neglecting evidence that may seem contradictory to our existing beliefs. Excuse me. So in the medical context, this may look like refusing to consider alternative diagnoses once an initial diagnosis has been established, even if lab results are indicating that there's evidence present for a contradictory diagnosis or a different diagnosis altogether. So obviously this can lead to mistaken diagnoses being passed on and accepted by other clinicians without the validity of those diagnoses being questioned. And there is a term for this, it's called diagnostic momentum. So once a diagnosis has been written down and put in your chart, then every other medical professional might review that and consider it to be, you know, the holy grail in terms of what's happening for you. So confirmation bias is something that it's, again, about perception. You know, some people might see a 6 as a 6 and others might see that 6 as a 9. So it's all about how you're reading the facts that are available to you. Okay. The third common bias that I want to highlight for us today is related to the availability heuristic or availability bias. So this basically says what comes to mind quickly is deemed significant, even if it is incorrectly present. So if you think about it again in the medical context, sometimes doctors are meeting with their patients for 15, 20 minutes, and they have to quickly churn out both the presenting concerns and problem solve through existing challenges that the person might have, but also move that person along in their treatment. But if, for example, a person is developing more invisible symptoms. For example, blood pressure, high blood pressure is very common when you have diabetes, but high blood pressure is an invisible symptom of a different illness. But if the doctor doesn't have time and they're only focusing on one aspect of the diabetes condition, and of course, as the patient, you're not noticing any significant challenges or visible challenges being present in relation to your blood pressure, you're not going to bring it up. But the doctor is also not going to bring it up because there isn't that much time available, and they're going to work off of the information that is presently available to them. So that might mean that complications get overlooked, or things that could have been prevented are not, because of the lack of a deeper dive that's necessary at that time. So we have all the appropriate information that we could be looking at, but the availability bias says we're only going to look at this one teeny tiny dot from that information, because that is the most recent information, it's the most frequently available, it's the most extreme or vivid information available, and potentially it could also be the most negative. I've worked with a number of clients who have said, I was doing really well with managing my diabetes over the last 2 months, and I was so excited to go and tell my endocrinologist about this information. And when I got there, we only had 20 minutes to chat, and the doctor only focused on all the things that I still needed to improve, or made me feel like I wasn't doing enough, or I was taking the wrong steps. And that, and from my perspective, a lot of times has to do with the fact that the doctor is not able to engage in, again, a deeper analysis, a deeper evaluation, because they have to focus on the information that's just at hand. That's not an excuse, but that tends to happen more often than not. At this point, I want to kind of switch over to talking about TechQuity. Now, we know what all these biases are. We know that they're going to specifically impact how folks are diagnosed, if they're correctly or incorrectly diagnosed. We know that they're going to these biases are going to impact what types of resources are available, interventions are available, what kind of treatment is available, but also it's going back to diabetes technology, it's going to impact whether or not the conversation around diabetes technology is even had with the healthcare provider. Okay, so all of that information is really relevant to the healthcare setting. So this is potentially all the biases that are present when we're interacting on a one-to-one level with a provider, in person, or even via telehealth nowadays. One of the things that I had mentioned earlier that the pandemic has introduced for us is the idea of digital solutions, trying to level out and provide equal resources across the board for all communities via a digital space. So challenges and barriers such as transportation to the medical office, or needing to take time away from your workspace, or taking time away from your children, some of those barriers are removed in getting the appropriate access to healthcare that you need. I want to switch over to talking to TechQuity because at this point, there's a certain trend that's developing that is potentially replicating what's happening in the healthcare system, but now in the digital health space. So let me walk you through what I mean by that. TechQuity refers to the strategic development and deployment of technology to advance health equity. Okay, so this can look like a variety of different things. But for our purposes today, this is referring to how technology can be used to improve the lives of people of color living with diabetes. So very quickly, I want to show you, I want to introduce to you a scientist at MIT. Her name is Joy. Some of you may already be familiar with her. There was a Netflix documentary that was completed that demonstrated, it highlighted the work that she has been doing. So her work is really focused on racial and gender bias in facial recognition. We're gonna watch a quick video on that. But we're switching over to discussing how digital solutions are now also replicating and creating their own biases in relation to what type of information is available, what type of resources are sourced to you when you are engaging with a digital health solution. Okay, but first let's meet let's meet Joy.
Google Career Certificates.
Of course, we're gonna have a ad before we get to our video here. I'm going to just show you a quick minute of this video, and then you can watch the rest at a later time.
And I research how computers.
Let me start that over because I think there's a delay. There you go.
Hi, I'm Joy, and I research how computers detect, recognize, and classify people's faces. In my TED featured talk, I spoke about my experience with the coded gaze, my term for algorithmic bias. The system I was using worked well on my lighter skinned friend's face, but when it came to detecting my face, it didn't do so well until I put on a white mask. After my talk was posted, I tested my speaker image profile across different facial analysis demos. 2 of the demos didn't detect my face. The other 2, well, they misgendered me. The demos didn't even distinguish between gender identity and biological sex. They just provided 2 labels, male and female. Now I wanted to see if these results were just because of my unique facial features, or if this was something that was more of a pattern across other faces too.
Okay, so that's a little bit of a teaser, but I'll give you the takeaway. It was a racial bias and a gender bias that was present across other faces as well. So if you haven't already, check out her Netflix documentary, and then also definitely finish watching that video. But the point that I want to highlight here is that similar to how communities of color have felt invisible or been invisible in other in the healthcare setting thus far, that same idea is now potentially being carried over into digital solutions that are developing. Okay, so we're gonna use the example of the sort of the biggest algorithm that's out there, which is Google, something that we all use on a regular basis. And I'm going to go through a few examples of how it's demonstrating bias at this point. So when you go to Google, I should also mention that some of these results may vary, because what I see when I Google search some of these terms is going to be different from what you see, because again, there's an algorithm there to figure out what are things that you like seeing, don't like seeing, what are your preferences, etc. But there should be some level of consistency across the board, but the results may not be exactly the same. So when you Google search teenager, this is what typically pops up. If you want, you can follow along in the chat here and kind of provide your comments of what are some themes that you're seeing in these pictures. And I'll give you my take on it as we move forward. But basically, you're seeing a lot of teenagers that are not of color pictured in this list of images. You're seeing a lot of light-skinned teenagers having a good time, not really, being too worried they're being teenagers, right? Okay. This is what happens when you do a Google search with 3 white teens. Again, lots of happiness, lots of good times being had. You're seeing a lot of sort of positivity associated with these pictures. This is what happens when you Google search 3 Black teens. What is the difference that you'll notice here? I should mention that this particular issue has already been brought up a few times. And so Google is now making an effort to diversify and update their algorithm. So some of these changes might have already been made, but this is how 3 Black teens are represented on a Google search page. So we went from very happy, very lively white teens to 3 Black teens that are basically, they are mugshots. There isn't a whole lot of positive representation here. And this is sort of the first 2 rows of what you will see. Okay, let's continue. Let's Google search doctor. This is what shows up when you Google search for an image of a doctor. What do you see here? Again, lots of white faces, but not a whole lot of representation of doctors of color, doctors who might have different accessibility needs or different ways of being with their patients. It's a very sort of generic idea of what a doctor should be. So when a little boy or girl of color looks at this and they're doing their Google search for their book report or whatever it might be, this is what they're going to see, and that representation is missing. Same thing with endocrinologists. There's not a whole lot of representation here either. Okay, let's look at type 1 diabetes. So all of you who are living with type 1 diabetes will probably already be familiar with this idea, but a lot of times when you Google search for images around type 1 diabetes, you see a lot of images of kids, but not a whole lot of adults living with diabetes, right? And similarly, there's not a whole lot of representation of adults of color living with type 1 diabetes here, right? So again, if you're a person from a community of color and you're Google searching what is type 1 diabetes, if you've just been diagnosed, you're not going to find a whole lot of representation from your community here. So you're going to feel different, potentially more biased and maybe even more depressed and more anxious about what is this that's happening to my body, right? Because there's no models available of how you could be interpreting this information. Okay, let's look at type 2 diabetes. So remember that stat that I shared early on in this presentation today that said 1.5 million people are diagnosed with diabetes annually in America, and majority come from communities of color. This particular algorithm is not showing us those results. This is making it a predominantly a disease that does not impact communities of color. So again, the representation here is missing. And when you come from a community of color and you don't know how to talk about it, what you're talking about, what questions to ask, most of us end up going to Google if that's the main resource that we've become accustomed to. And if this is what's being presented to us, then we don't know specifically what to do. Going back to diabetes technology, this is what shows up. A number of very slim, very model-like and very white insulin pump users. There isn't any, there's no tummies of color on this particular Google search image. So that again speaks to how often and how little communities of color are being represented in these images over time. Same thing with the CGM. We see lots of white arms. We don't see a whole lot of brown and black and every other shade of brown and black in between represented here. So this is a pretty significant challenge that I don't know if Google is going to be able to address immediately, but we as communities of color need, and advocates of communities of color need to be aware of this, because this is what is driving the information that we're receiving and how decisions are being made about our communities and the resources that are available to our communities of color. Okay, so I'm gonna summarize some of our findings here so we can start thinking about what do we do moving forward, right? So in summary, we know in the healthcare system, cognitive biases amidst the medical community can fuel misdiagnoses. They can limit the intervention options that are discussed with communities of color. They can inhibit the treatment options, including diabetes technology options that are discussed and provided to patients of color. And then in the digital space, we're seeing some of the same ideas come up over and over again. There's algorithmic bias now, that is inhibiting what images, what information, and again, what resources are surfaced. So if you're already feeling apprehensive about having diabetes, type 1, type 2, whatever it might be, and you're seeing that majority of the technology resources that are available are not available to all communities of color, or there aren't representatives from communities of color talking and using those technology resources, then you're going to also feel inhibited about when and why and how you would utilize that diabetes technology as well. So this is important because COVID-19 has introduced us all to more digital health solutions as a potential ongoing resource. The idea of digital health solutions is meant to create equitable spaces. However, we have to get ahead of this right now because we want to avoid the patterns that exist in the current healthcare setting. We want to avoid replication of those patterns in the digital health solutions that are being developed as we speak in the modern world. And I think the more representation, more discussion that we can have around it, the easier it'll be to make sure that our voices are heard. So what can we do? How do we improve TechQuity? How do we improve the reduction of these cognitive biases, both in the healthcare setting and in the digital health solution? One, we have to inform ourselves and our communities about what is going on. Once again, we do not want to be the invisible voices where our voices don't get heard, but also that our voices are not respected or at the table when these decisions are being made. We want to work with companies. So whenever you're using a product of any kind, diabetes related or otherwise, be aware of, is this a company that's promoting equity, or is there some level of bias present within their own algorithms? And of course, you can always do a quick search, and a lot of these companies, yes, they're making more efforts, but some of the ones that are not, they will definitely be in the news about it. But if a company is proactive in their equitable actions and desires, they will make that pronounced in whatever communications they have available for their external members. So, and the other part of this is to continue to advocate. I know we have a great talk coming up later on how to become a self-advocate. And it's unfortunate that we have to do so much self-advocacy everywhere we turn. However, in this space, I absolutely believe we need to hold others accountable. And therefore, we need to start addressing the fact that TechQuity related issues are still present, even in this new forum where they're not supposed to be present, digital health spaces where they're supposed to be, again, a more equitable grounds for all of us to receive equal services. But we have to make sure we're educating ourselves so that we can become better advocates over time. So that is my call to action for TechQuity. Thank you so much for listening today. If you would like, I have all of my ways that you can follow me. I'm very passionate about TechQuity and making sure we're reducing medical bias and creating digital solutions that are going to be absolutely helpful and useful and have communities of color represented wherever they possibly can be and should be. They should be represented in all the different spaces that exist out there. So please definitely reach out if you have additional questions or thoughts. I thought I would leave it up to the last 15 minutes to answer any questions that might have come up for folks as we wrap up right now. So I'm open to questions as we move forward.
It's been wonderful, Dr. Nagra. Can you go back one slide? I would really love for people to snap a picture of this call to action. And you're right, Casey and I do have a presentation on advocacy and allyship because it's so important. In fact, we say don't just be an ally, be an accomplice. So definitely go and check out that session later. This has just been phenomenal. So let's definitely answer this call. We don't have any questions in the chat right now, but we have a few minutes. If you do have questions, to please put them in the chat right now. I think we actually have the Q&A turned off. so that we can address those in the time that we have allotted. It looks like Casey says there's also a community group self-advocacy session. That is correct. Just really, really important points. Thanks so much for the imagery that you provided in this presentation as well, because sometimes we need that to really invoke emotion. And we know as an organization, when trying to find images of people with diabetes of color using insulin pumps and using CGMs, or giving themselves it's so difficult to do. And so thank you again for really highlighting that point and bringing it home. So we all have lots of work to do for sure. Definitely lots more work. So no questions right now, but I'll leave you with any final words or comments.
Yeah, I would say, one of the things that I always talk about, and I didn't mention this, I think we have a question. Maybe I'll come back to that. Let me see what the question is, and we'll come back to it. So it says, Sarah's asking, how can we address the potential disparities in access to CGMs, getting more insurance companies to cover them, or assistance programs? I think there's a lot of sort of systemic interventions that we can definitely address. But I think one of the first things that I worked in a diabetes center where I was the sole psychologist for about 5,000 different adults who had type 1, type 2, late onset, pretty much anything you can think of, pre-diabetes, gestational, et cetera. But what I noticed as, being a psychologist of color was that the folks who came from non-Hispanic white backgrounds were bigger advocates. So they would be on their doctor about the insurance company not giving them the CGM, or giving them a tough time about getting the CGM. And so the doctors were the ones who were doing that advocacy for the person to get that insurance to cover their CGM. So it wasn't necessarily the person sitting on the phone for hours upon hours and making those requests. It was the medical provider who was saying, you need to get this individual on the CGM, otherwise it's a life-threatening condition. And it's going to be essentially any problems that come up, it's going to be the responsibility of the insurance company to manage that and deal with that. So if you have the medical professional making those calls for you, I think it goes much further rather than you trying to do that alone. So in addition to that, I would say that the policy level advocacy that we can do is also pretty significant. So if you have folks in your local area who are working on diabetes related advocacy to get more insurance companies involved and get more diabetes technology approved, definitely support them, join their social media, whatever it is that you're capable of doing within your allotted time. Definitely support their efforts along the way too. And I would also encourage Keisha and Casey to jump in on this, because I know you two have a lot of background in this as well.
Yeah, I think a lot of what you said definitely comes is better received coming from the physician as well. We're having some technical difficulties. I can't turn my camera on, I think, because I gave away my access. But that's one of the things that we're trying to do is here in the middle on the screen, you've got work with companies that promote equity, right? And so we're trying to find the best partners to be able to do this, because we do know that this is one of the biggest areas that people really struggle with, is being able to afford this type of technology that ultimately will make their diabetes easier to manage. And like you said, there's no easy solution. There's so many different ways that we can attack this. So just still putting our thinking caps on and trying to figure out the best way to approach it for sure.
Yeah, definitely. If there aren't other questions, the comment I was going to make earlier is that one of the things that's inherent to communities of color, and one of the things that I struggled with when I was in training to become a psychologist, was that a lot of the Western ideals around what is supportive of mental health, they're very much focused on only focusing on talking with a professional, but your internal communities and internal resources are not as valued or as highlighted as often. And I think for communities of color, especially our families, our church communities, our smaller communities that we belong to, really impact how we feel and act day in, day out. And that also means that when it comes to any sort of resource challenges or additional support that we might need, we need to be able to access our communities quickly and regularly in order to feel like we're part of that larger social system. The reason I bring that up is that when it comes to TechQuity issues or resource issues like diabetes, getting access to diabetes technology, I think it's okay to go to your family or friends, or your local community, your church, whatever, your school, whatever it might be, to get additional folks involved, because there might be other folks who are going through similar challenges. And there's this really great quote that I'm a big fan of that says, "We don't heal in isolation, we heal in community." So we need to be able to find what our community is going to look like in order to definitely raise our voices in relation to any type of TechQuity concerns that might be coming up moving forward.
I love that. I have to put that in the chat. I think that's wonderful. I've always heard community is the cure. And so that's so true. Thank you again for such a wonderful presentation. Looks like people have really enjoyed it. Again, thank you for opening up our 3-day summit with this presentation. It was phenomenal and exactly what we need to set the tone for the rest of the summit. So everyone, thank you so much for attending. Please go and check out our other sessions that we have. Some are available pre-recorded, and we do have another live session in the next hour. So go back to the agenda and check those out. Thank you all so very much for just supporting and doing the work that you continue to do every day. It does not go unnoticed, and you are appreciated.